Okay, good morning, everybody. I'm Robin Strongin, the president of Amplify Public Affairs, and I'd like to welcome all of you here. This is the Comparative Effectiveness Research panel, and we are going to be talking specifically about how head-to-head trials and comparisons will impact patients. And because that's our topic on this broad focus of comparative effectiveness research, we thought we'd do something really radical. So we have a patient on the panel, and rather than talk about patients, we actually have someone, and obviously each and every one of us are and have been and will be patients at some time. At these kind of meetings, we tend to look through the lens from which we are experts in, and so we're very, very fortunate to have Rhonda Monroe with us today to really bring it back to the main point, which is about the patient. And the way we've framed today's panel is to bookend it with some policy discussions, broad view policy. And Phyllis Greenberger, the CEO of the Society of Women's Health Research, who we're running ragged at this conference, has been on multiple panels already, is going to talk to us about the overview, but also about some of the issues that are obviously relevant to her through the lens that she spends her time working on. Then what we thought we'd do is drill down a little bit with two case studies, look at two diseases. So we're going to look at the issue from the viewpoint of heart disease and cancer. And I'm delighted to introduce Lisa Tate, president of Women Heart, who is here along with Rhonda Monroe, as I mentioned, and the two of them will take a look at comparative effectiveness and the relationship with heart disease. And then I'm delighted to also introduce Wendy Selig with the American Cancer Society, the Cancer Action Network. And obviously, Wendy will talk to us about comparative effectiveness and how it relates to cancer. Then we're going to come back up to a broader policy research level, and we're very honored to have Cliff Leaf be able to join the panel today, who's a very well-known journalist and passionate advocate and has some really provocative questions and challenges for us to be thinking about when we talk about comparative effectiveness and health in general. Can we take the models that work in other sectors and apply them to healthcare? Sometimes we can, sometimes we don't do it so well. And so he'll really challenge us to start thinking about all this and tie up all the loose ends that we have raised. So just to take a step back in terms of setting the stage, last month, the Federal Coordinating Council for Comparative Effectiveness Research issued its report to the President and to the Congress, and I just want to throw out the definition that they use so we're all working off of the same definition, because obviously terms get thrown around quite a bit inside Washington. So their definition, the one we're pretty much sticking to, is the conduct and synthesis of research comparing the benefits and harms of different interventions and strategies to prevent, diagnose, treat, and monitor health conditions in the real world. $1.1 billion has been allocated for comparative effectiveness research within the health reform debate efforts that are going on. We'll see where that goes. It is not a new concept by any stretch of the imagination. And furthermore, most people are in agreement that having data available, having the evidence to make informed decisions between a health provider and a patient is a really good thing to do. Where it gets sticky is when you start to think about how do you do it, who does it, how do you set priorities, are we leaving people out? Are we leaving innovations and discoveries on the table because of policies? What are the unintended consequences? Lots of really tricky questions. And the mother of all tricky questions are, do we use it to make coverage, payment, and reimbursement decisions with that data? So with that, I'm going to turn it over to Phyllis.
Thank you. Well, Robin has set the stage well, I think. Comparative effectiveness, actually, in Washington, they use sort of these terms interchangeably, which is also sort of confusing, is clinical effectiveness and cost effectiveness. And, of course, when they use cost effectiveness, that's when all the furor arises. What's interesting about this issue is that healthcare reform encompasses a huge amount of issues, as I'm sure you're aware, and many pages of legislation. And comparative effectiveness started out as being sort of one line in a piece of legislation which created this enormous panic among certainly the patient organizations and industry for obvious reasons that Robin referred to. And so it has become sort of a major issue at the sort of the center of the whole comparative effectiveness debate. And as Robin said, the people on the panel will be looking specifically at lung cancer, which we know have differences in terms of sex differences and prevalence and prognosis, which I will explain a little bit more. And of course, as she said, Lisa will be talking about differences in heart disease, and Rhonda, I think, is going to give probably a fabulous, as I've heard, sense of how that affects the patient. So what I'm going to try to do is do an overview. It's not disease specific, it's just an overview of comparative effectiveness in general. So when the Society for Women's Health Research, my organization, first learned of comparative effectiveness, we were very concerned. And of course, I still have concerns, and as they say, the devil is in the details, and the details are still to be determined. Now, let me just say that I don't know about the other panelists, but in Washington, CE or CER is comparative effectiveness or comparative effectiveness research. So I'm going to be referring to CE or CER, and that's what we mean. For those of you who have heard my other presentations, I apologize for this, but I need to, for those of you who haven't, tell you a little bit about my organization and what we care about. The Society for Women's Health Research is dedicated to advancing research into sex differences, which we believe will improve care for both men and women. And you've also probably heard, if you've been in the other sessions, that we know actually relatively little about sex differences because until fairly recently, women were not traditionally included in clinical trials. And when they were, and frankly, when they are now, in most cases, sex analysis is still not being done. So while we do know more about the conditions, about incidence, prevalence, and symptoms of many conditions, we still know very little about how those differences affect prevention and treatment. So in the Society's multiple letters to the committees on the Senate and the House side, writing the legislation that addresses this issue, and our comments to the Institute of Medicine's committee charged with setting the priorities for CER, we listed a number of concerns. First and foremost, that comparative effectiveness has to be based on clinical effectiveness, not cost. And as I mentioned earlier, there were a number of members that uttered the term cost effectiveness at the beginning, and the whole patient community was in a panic. So here are our first priorities as we list them to the House and Senate staff and also to the IOM committee. One, that research has to ensure the most effective treatment available, that the research studies both men and women and analyzes for sex-based differences in disease prevalence, treatment options, and procedures, as well as responses to treatment. That research must also take into account the differences in effectiveness within subpopulations and study how certain treatments affect different types of patients by accounting for sex, race, age, genetic and molecular subtypes, quality of life preferences, and comorbidities. Furthermore, we believe it's important to have patient input so that they have a voice in the process and that communication of the findings clearly explains which patients benefited more or less from which option. And of course, we stressed that CE should encourage additional research into sex differences. Now, having said all that, there have been plenty of articles recently in the press and in scientific journals. In fact, I think the New England Journal devoted a whole issue to it, to stress the intent, hopefully, and the reality to provide information that they think that the comparative effectiveness will provide information that will help clinicians and patients choose the options that best fit an individual patient's needs and preferences. And of course, the hope and the belief by some is that it will be able to hasten the discovery of the best approaches to personalization, providing more and better information with which to craft an individualized strategy for each patient. Again, the Society's concern is about what data is going to be used to make the decisions, since women have not been in many of the studies, and the results, as I said, were not analyzed. So here we are.
You know, they don't amplify sound. It's only for the recording, so we'll try to speak a little louder.
Sorry. So the Society's concern is about what what data is going to be used to make the decisions, since women, as I said, have not been in many of the studies and the results haven't been analyzed. So we're focusing here on drug therapies and interventions where we know there are differences, but we have incomplete data on which to base decisions about effectiveness. Research results, whether for men or women, as we know now, are slowly disseminated, and it can take literally years for translation of research into clinical trial, into clinical care. And we're fully aware of the disparities in service delivery and uneven incorporation of best practices. So if the infrastructure of CER can expedite the dissemination of that information, then clearly that's a positive outcome. Again, the devil's in the details. How will it be done? By whom? What metrics will be used? That all remains to be seen. My last comment is directed to the Institute of Medicine's report, which was entitled Initial National Priorities for Comparative Effectiveness Research. And this was in response to a mandate by Congress to basically look at comparative effectiveness and develop a list of priorities. And these are clearly initial ones. They are not the final ones, and there probably won't be so many. Right now there are 100. There are several subgroups listed, and once again, unfortunately, as I've mentioned earlier this weekend, women's health is defined as OBGYN issues. Although a report states that the initial 100 priorities listed, subgroup analysis must be considered on demographic, ethnic, physiological, and genetic characteristics. It does not explicitly state anywhere in the report that sex and gender differences should be considered. Now, we were told that it was implicit, but it's been implicit now for a long time, and we want it explicit, not implicit. The Society recommends that sex differences be at the heart of comparative effectiveness research, evaluating and comparing the clinical effectiveness, risks, benefits of 2 or more medical treatments, services, drugs, devices, biologics, care processes, and care management, while also taking into account differences based on a patient's sex, age, race, and ethnicity. And the research results must avoid creating unintended access barriers, coverage denials, or arbitrary dollar thresholds that can arise through centralized cost-effectiveness determinations. And by focusing on gaps in clinical knowledge, the research findings, we hope, can improve the quality and ultimately the value of health care. So as it's proposed in this report, we think it still fails to advance the knowledge of the science of sex differences, which obviously we have stated is our important goal. And so we would like to see also that as the priorities are listed and they have categories, there's actually a graph of categories of different diseases, and women's health is separate, defined as OBGYN, which is what we are and have been trying to get away from now for the last many years. We would like that definition to include all conditions, not just OBGYN, not only OBGYN conditions. So at the moment, and while we are still working on this and we are still corresponding and we will be writing a letter to the IOM, we do find this report lacking in sufficient knowledge about women's health and the consideration of sex and gender differences. So we're at the table, and we hope to continue our education and that this, in fact, will be focused upon. But this is, as you will hear from the rest of the panelists, and as Robin said, this is not even easily said, but certainly more difficultly done. So I think this is going to be a topic of conversation and a lot of debate and concern about how we're actually going to do this and how we're going to disseminate the results. Thank you.
Thanks, Phyllis. And now Lisa.
Great, thanks, Phyllis and Robin. Great to see you all this morning. Thanks for being here. What I wanted to do in my few minutes that I have is give you kind of a bird's eye view of the challenges that women face, women who are living with heart disease today, and then specifically relate those challenges to comparative effectiveness research and how potentially it could alleviate some of those challenges and also potentially exacerbate some of them. Just a little bit about my organization. It's Women Heart, the National Coalition for Women with Heart Disease. We're the nation's only education, advocacy, and support organization for women living with heart disease. We do advocacy on issues, policy issues ranging from health reform to funding for research, et cetera, those all issues that would impact a woman heart patient. We do support for women with heart disease. We're the only national group setting up a national network of actual support groups for women with heart disease, which exist for every kind of cancer, and breast cancer, most notably, but don't exist for women with heart disease. And we also educate women in all the normal ways that an organization would do that, but in one unique way, and that is that we train and then run a network of women heart champions, women who are living with heart disease survivors, who we educate in the medical and scientific aspects of heart disease, along with, in collaboration with the Mayo Clinic, and then who go out in their own local communities and tell their own very unique personal stories, along with this medical and scientific information, because what we have found is that there's nothing like a personal story from a woman who's been there that really can make someone sit up and understand their risk of heart disease and take action to alleviate those risks. We like to say that we're the boots on the ground or the high heels on the ground in the fight against heart disease in this country, and you'll be hearing from one of our stellar volunteers, Rhonda, here in just a minute. So with heart disease being the #1 killer of American women, but still unfortunately perceived as a man's disease, there are a number of barriers to women receiving both preventive care as well as early and accurate diagnosis and even proper treatment after they have been diagnosed. One of those barriers is lack of awareness among women themselves that they are at risk for heart disease, lack of awareness of risk factors, everything from family history to depression and how that can relate to heart disease, and lack of awareness about the signs and symptoms of heart disease or even a heart attack, which is really critically important. There have been recent campaigns. Betsy Nable's here, who runs the National Heart, Lung, and Blood Institute, runs one of the biggest campaigns, national campaign through the government, to raise awareness of women's risk of heart disease, and that has had some effect. These are recent campaigns over only in the last 5 to 7 years. And so awareness has generally been rising. I think the numbers are about 60% now of women just knowing that heart disease is the #1 killer of women. But still, that's really just scratching the surface. And those numbers among African American women and Latina women are much lower, and they are, in fact, at much higher risk of heart disease. Unfortunately, another of the barriers, even more significant, is lack of awareness and provider knowledge, actually knowledge by healthcare providers themselves about women's risks and appropriate treatment, which leads to inadequate care and care that does not meet evidence-based guidelines and standards of care that have been approved by the American Heart Association and other bodies. We hear these stories every day, anecdotally, and the research also underpins those stories that we hear from our volunteers and from the women who contact our organization. And I'm just going to cite a couple of them for you all that don't live these kind of statistics and these stories every day. But just this year, there was a study published that showed that women are delayed 50% more likely. They're more likely to be delayed to receiving emergency care services from EMS and being taken to the hospital than men are. And the study pointed to the reasons for that being that EMS and women themselves not recognizing that the major cardiac event that they were experiencing was actually cardiac related. And also to the cardiac symptoms, heart attack symptoms slightly differing among men and women. Another 2008 study showed that women with acute coronary syndrome, or ACS, were less likely than men to undergo cardiac catheterization and other therapies, receive beta blockers, statins, and even be prescribed simple aspirin. Women just don't get the same aggressive therapies that men get. Another study found that women were 40 to 50% less likely to have an angiogram, a diagnostic test, than men. So today, women are living and challenged by these disparities in care, even before we get into the comparative effectiveness research issue. Finally, the other significant challenge that Phyllis noted and has talked about earlier is the underrepresentation of women in clinical trials. And this is particularly important for women with heart disease because of the prevalence of the disease. In NIH-supported cardiovascular trials, despite a 1993 federal law requiring a proportionate number of women be included, there's a serious lapse, and they are not meeting their own goals that they have set. The same thing with the FDA, that they have their own rules and guidelines about how many women should be included in clinical trials for applicants for FDA approval, and they are not meeting their own guidelines either. So today, women are being treated with drugs, procedures, and devices that have been tested in men and in some women, but very likely and too often not in sufficient numbers of women. So I think that, the bottom line today in women's heart disease is that women aren't getting the prevention, the appropriate care, and the research that they should be. And so the question is, does CER help this situation? Is this a promise, or is this a pitfall that is going to exacerbate the situation? And I think that the answer is simple. There are three of them: yes, no, and maybe. So yes, if CER is done right, I think it does have great potential for patients and women with heart disease specifically. The data can be more accessible. If CER is done right, will be available to patients and can inform their choices. It can help them have better conversations with their healthcare provider and help them advocate for their own care. Again, our organization is all about making sure women have the information that they need so they can advocate for their own care if they're not getting the care that they need to. And CER could be a positive in that way. Also, if CER is done right, there's going to be more data and information available to physicians and to other healthcare providers. Again, they can help close some of those knowledge gaps about appropriate treatments and what the protocols are. And not just the clinical research, but actually healthcare delivery, what's happening in a clinical setting. Because I think that's something that we see, particularly in women's cardiovascular care, that it's not just the scientific research, but how that translates into care. That's where often it breaks down. It doesn't ever get to the bedside. If CER is done right, we also think it can ameliorate some of this data gaps if it's done correctly, and that we're really looking at the analysis of men and women and gender and sex and looking at the data that exists. And another positive, at least from our own kind of self-serving aspect, is that in the IOM report, in all the recommendations that they made, the 100 areas that they pointed to as being the priority areas for CER research, that cardiovascular research and peripheral vascular disease research ranked number 2. So we're pleased about that, from our own perspective. However, with these positives, we also see pitfalls and things that could seriously impact women in a negative way. First, we're extremely concerned that CER will limit itself too heavily to looking back at data, to data that has been collected and not new data. And if that's the case, we're building on historic data that has historically underrepresented women in trials and in research. And so that could pose a big problem for women and the recommendations that come out of that. And there has to be a new data gathering and new analysis that specifically breaks down the data by gender and sex. Secondly, we're extremely concerned, and Phyllis touched upon that the data can be used to reduce or eliminate access to treatment options. If cost data carries the day, and if that's the decision-making, the real decision-making pressure, patients are going to be seriously harmed, particularly women with heart disease, because women with heart disease need more access, not less, to both existing treatments, as I've noted before, as well as new and breakthrough treatments. So there's pros, there's cons. Some of the safeguards that we think can make CER work the best for patients are the following. Number one, that it needs to be patient. Everything in the CER process has to be focused on the patient, not on the facility, not on the payer, not on the researcher, but patient-centered. And making sure that we're safeguarding the rights of patients, as well as making sure that we're looking at all the conditions in all parts of the country, especially rural areas where where treatments and services are not going to be as easily accessible as they are in other areas. Number two, that the research must be evidence-based. Phyllis noted this, obviously, and also look at subpopulations. Again, we heard in Phyllis's last presentation that, women are 52% of the population, but we're considered a subpopulation. Go figure. Thirdly, transparency. Transparency must be a part of the process in all levels, making sure that stakeholders can easily find out who's conducting the research, who's financing it, who's analyzing, what metrics they're using, and how decisions are going to be made. Because again, maybe for the individual patient, that's less important. I mean, they may not be all like Rhonda, who would be looking at that data, but for patient advocacy groups that are like ourselves, we're going to be monitoring that very, very closely. Number 5, rapid translation of the best available evidence to clinical practice has got to be ensured in the process. And I think from some of the studies that I noted earlier, this is one of the things that is just particularly important, because all the data in the world and all the research in the world is not going to be any good unless it's translated to the bedside. I think that in heart disease, you don't have to look very far to find examples of this. I mean, I think the most obvious example is PCI. It's an intervention that basically opens the artery when you're having a heart attack. And there was a lot of data and research done in the 90s that showed that the optimum time to have that happen was about 90 minutes. And research was, all kinds of studies came out about it, et cetera. It took 10 years. 10 years after that research came out, only 1/3 of hospitals were getting the PCI intervention to the patient within that allotted 90 minutes of time. So that's just one example, but there are hundreds of those where it just doesn't get translated down to the bedside. And so from a patient perspective, what good is comparative effectiveness research or any other research if that doesn't happen? And finally, last but not least, comparative effectiveness has to ensure that the full range of effective drugs, devices, and therapies remain available to patients, that they're assured for patients, all patients, as well as patients who may be outliers, patients whose other treatments have not worked. And I think Rhonda's going to specifically talk about that as a very perfect example for her own personal experience. So again, if cost rules the day, that is going to be a big problem for patients, and patients will lose in the end. I'll close with our comparative effectiveness mantra, but it's really our mantra as an organization for everything, which is patient-centered, for the good of the patients. Patients rule. That's what we believe, and I think when Rhonda talks, you'll hear why, even more so than anything I could say. And I said to Rhonda earlier that I was really happy I was speaking before her and not after her, and that's for sure. So thank you very much.
Thanks a lot.
I'm sorry, Wendy, but
I'm Rhonda Monroe. You've heard me mention a couple times, and I really am at the center of this debate. I'm the reason why we do any of this. I'm the patient, and I should be at the center of this debate. But first I want to tell you good morning, and I feel privileged to be among those invited here to weigh in on this important issue. Comparative effectiveness research is a hot topic, and it's hotly debated these days, and those who are at the forefront of healthcare reform have now decided that we should decide when and where and how this research should be applied, can be applied, and the limitations, if any, should be implemented. I'm a living miracle. I'm happy to be here today because it could have been catastrophic, and while it was catastrophic to a certain extent, it wasn't fatal. Why? Since May 2004, I've died 3 times. I've had 3 heart attacks, 5 of my coronary arteries dissected, which means they tore. To put it in perspective, John Ritter of Three's Company fame had 1 dissection. He's no longer here. I've had a quadruple bypass. I've had a double bypass. I've had angioplasty. I've had stents. I've had 15 laser holes drilled in my heart. I've had part of my heart cut off. I've had 2 defibrillator implants, a pericardial window, and then some. I am the bionic woman. On top of all that, this happened 5 days after I gave birth. I was 5 days postpartum, nursing my daughter, took her off my breast later in the cradle, and proceeded to have a massive heart attack. Laid back on the bed, and the elephant sat on top of me promptly, and I bounced back up. I looked in the mirror. I said, am I having a heart attack? think I am. No, I'm too young to be having a heart attack. Yep, I'm having a heart attack. And so I was misdiagnosed for 7 days. I called 911 immediately. The EMTs came, took me to the hospital. They did the standard heart attack protocol, so kudos to EMTs. They gave me aspirin, morphine, did the EKG. It said I was having an acute myocardial infarction. I get to the emergency room, and they take one look at me. Here I am, this 36-year-old, skinny African-American female who doesn't fit the bill of a typical heart patient. And so I presented with every classic symptom: crushing substernal chest pain, that elephant that was sitting on my chest. I broke out sweating. I vomited. I had nausea. I had numbness and tingling in my left arm. And an EKG that was clearly abnormal. The only problem, I wasn't a middle-aged white man. You can't be having a heart attack. Well, I was. And so, indeed, I've survived a tremendous ordeal in the past 5 years. My daughter is 5 years old now, yay, and she's healthy and fine. But I want you to understand that I am the exceptional patient. And I'm not the rule when it comes to research and analysis. My story defies conventional wisdom. Surviving seemingly insurmountable odds, however, has given me a unique perspective on comparative effectiveness research. Balance my personal health experiences with the fact that by trade, I'm an economist. Well, I was an economist in my past life prior to my health problems. I have degrees in economics and finance and an MBA, so I'm an analytical thinker. But my patient experience leads me to come to some different conclusions. But my personal experience really juxtaposes what I believe is at the core of this debate over CER. It's the practical application of empirical data. I'm a person, but we have evidence that says something. And how do we make the two meet? What do I mean? Well, the economist in me says, gather all the data you can. The more information, the better. For the most part, data is good. And as Lisa indicated, and I'm living proof of, there isn't enough data to date, especially where women in heart disease are concerned. As a result, we've received disparate treatment. I just shared with you what happened to me on my trip to the ER, because we've traditionally been excluded from case studies and clinical trials. So knowing the efficacy of pharmacological therapies as well as invasive and non-invasive treatments and protocols could save lives and money. And that's a good thing. If the data is used by medical teams, of which the patient should be an active partner to determine viable options with successful outcomes, I'm all for it. Such knowledge could be applied to gender-specific studies, ethnicity studies, and the like. And the possibilities on that level are exciting. Conversely, data could be applied to eliminate ineffective treatments, and that too would prove beneficial. For informational and educational purposes, personalized comparative data opens up a world of possibility for physicians and patients. But are these the only people who are going to look at the data? See, questions are now being raised around whether insurance companies will be granted access to such data, and should, could, and would they use that as a basis for denying or approving medical therapies? I would suggest, as a patient, that they shouldn't, as a rule. While guidelines can be put in place, case-by-case analysis is required. Why? First and foremost, because people's lives are at stake. My life was at stake. Here's an example of what I believe to be an ill-applied across-the-board rule. Medicare, and I'm sure you're all familiar with Medicare, has an across-the-board policy of denying everyone except renal patients on their first application. So if you apply to Medicare, you're automatically going to be denied. Despite the fact that you've had 3 heart attacks, 8 surgeries, all of that is irrelevant. If you don't have renal failure, you're denied. They have an across-the-board policy. As a result of that policy, I laid in the hospital hooked up to a constant nitro drip, had oxygen to breathe, was on around-the-clock meds. I was sitting, awaiting death. I was on the long-term care ward of the hospital with a phone in my hand calling Medicare's office every day trying to get some benefits. How ridiculous is that? What kind of sense does that make? None whatsoever. And so across the board policies like that often prove ineffective. Why? Because individuals' lives are at stake. I lived it. But I want to consider my own personal series of catastrophic events. I told you 5 days postpartum in May 2004, I had a massive heart attack. For 7 days, I was denied adequate health care because conventional wisdom said that it was highly improbable, if not impossible, that I, a young size 6 African-American female, I was a size 6 then, African-American female, could be having a heart attack. I had no family history. I had no risk factors. I didn't smoke. There was no recreational drug usage. There was no diabetes, and I wasn't obese. And so conventional wisdom said, you can't be having a heart attack, despite the fact that I had classic symptoms and an abnormal EKG. My symptoms were dismissed. Why? Again, I told you already, I wasn't a middle-aged white male, and research says that these are the people who have heart attacks. We'll leave it to me to be cutting edge. You see, research indicated that it's much more likely that a woman of childbearing years have a pulmonary embolism. And so that's the path that they pursued. My feelings on that, if it walks like a duck and talks like a duck, if it's quacking, guess what? It's a duck. I was having a heart attack. But based on conventional wisdom, research that was available at that time, no one listened to me. They didn't even listen to their own reports. They dismissed them. So, fast forward 7 months, I've had the quadruple bypass, and now my bypass graft shut down. And I'm placed in the long-term care ward, being told that I wasn't going to live. I'm not going to live? What do you mean? You can send people to the moon and you can't save my life? They told me, conventional wisdom says, if a bypass graft shuts down in the first year, well, then your mortality rate, it's not good. It is true. And while that is true, I agree with that. Statistics support that. However, I'm not a statistic. I'm a person. Real, living, breathing human being with a life and children. And so I laid in that hospital bed for a month, praying for some doctor, a surgeon in particular, to have the courage to buck conventional wisdom, to have the courage to get beyond his thoughts of a malpractice suit that my family may file because he was certain that I was going to die. I was waiting for someone to take a chance on me, to buck the system and say, you know what, research says this, but this is a person, and I can see that she's fighting, and she has resolve, and so I'll take a chance on her. And so after a month, that happened, and he came back and he said, so many people have inquired about you that I'm going to take another look at you. And he did, and he said, I have some tests that I want to run you through, and if you pass this threshold of tests, then I'll operate on you. So I was given cutting-edge surgery, and that's when they cut off part of my heart. They did surgical ventricular reduction. I had TMR, transmyocardial revascularization, and they repeated the bypass. Well, the next week, I'm laying there again, and I have pain in my heart. I called the cardiologist, and they're like, okay, really, it's got to be in your head this time. You know, by now they think I'm nuts anyway. It's really got to be in your head. Well, it wasn't. My heart was tamponading. Now, at this point, conventional wisdom says, well, if this surgery didn't work and this surgery didn't work, why would we do a third surgery within 8 months? But he did, and here I am today, and I'm grateful for that. And so I've survived. And so after that final open heart surgery where they gave me a pericardial window, I made it through. And I made it through seemingly insurmountable odds. And so I ask you now, should the knowledge of widely accepted methodologies have been allowed to determine my worth? And how on earth would you explain that to my newborn and my 2 small kids? God forbid. But it could have come to this. We live in a world where we sometimes dismiss the obvious to save $1. And I wanted to holler every time someone said, "You're going to die." My reply, I've got 3 babies. So I'm going to fight and I'm going to try. Don't deny me that. In fact, isn't this America, the land of the free and the home of the brave? And yet you're asking me to resign myself to an early grave? We've become slaves to cost-cutting measures and monetary gain. And twain the two, there's no room for individuality. It almost happened to me, you see. But I am an individual, not some statistic or residual able to be categorized with the masses. I have something to offer and much more to say. Perhaps I was spared to address you here today. They say that everything happens for a reason. Could it be that my suffering will one day save lives? Then we can recategorize the astronomical costs of my surgeries under the category well worth it. I can't say that I deserve the second chance that I've been given, but I am glad to be among the living. Does comparative effectiveness research have merit? Absolutely. But it must be applied with the knowledge that individual lives are at stake. Fortunately, I'm living proof. Thank you.
Okay, Wendy.
So I'm sitting next to Rhonda, and my boss is in the audience. It's the second time I've heard Rhonda present, and each time I learned something new. And you're remarkable, and we're so glad you're here. And what I have to say is not nearly as interesting, but I'm going to try to pick up on some of the themes that the 3 of you laid out, and then you're going to have to try to tie it all together. So just a little bit about the American Cancer Society. I think everyone's familiar with the American Cancer Society. This is our CEO, John Seffrin, sitting here. Make sure I say the right thing. I work with the American Cancer Society Cancer Action Network, and we are the advocacy affiliate for ACS. We're based in Washington, D.C., and it's our job to promote the mission of the American Cancer Society on cancer on behalf of all people with cancer, women and men. But we do it through advocacy and public policy. So I don't have a science background, but I am pretty well versed in the ups and downs of the sausage-making process in Washington. And I think where I want to start is where Phyllis started, and that is the debate that's going on right now as we sit here back there around healthcare reform. And comparative effectiveness research, those words mean very different things to very different people. And we're at the point in the process, in the legislative process, where the volume has gone up, and folks are starting to sort of dig in and take sides, and the interest groups are coming out, and people are starting to get nervous. And I would like us here today, since we're in this beautiful setting, maybe we can ratchet down the rhetoric and talk about comparative effectiveness research is not the greatest thing to ever hit the planet. It will not be the silver bullet that solves all of our problems on the one hand, nor will it be the worst thing to ever happen. And I think really what we need to talk about is what is it, who's it for, how's it going to be done, will it be transparent, will the American public and patients and families be able to understand it and have confidence in it, and what's to be gained from it in a country like ours where we have a healthcare system that for some people can offer the best, and a healthcare system that for very many people, unfortunately, offers little or nothing. And how do we, through healthcare reform, get to a point where we get access to quality healthcare that people can take advantage of? And could research, take away comparative effectiveness research, but could research bring us to the point where we have rational delivery of care, not rationing of care? And I think, that's a little play of words that I learned from our chief medical officer, but I think that's really important. And I'm going to throw out one more little one-liner that I can't take credit for. Phyllis and I were in a room a few weeks ago listening to a terrific speaker from a pharmaceutical company who said, well, comparative effectiveness research, how about effective comparisons? And I think really what you've heard from all of us today, and it's very true in cancer, is that we are in need of better data. I mean, for all of the investment that has happened in research, and our organization has committed billions of dollars over its lifetime in cancer research, the American federal government, private philanthropy, tens of billions of dollars in cancer research. We've learned a lot about cancer and about the genome and about human biology, but yet there's still a lot that we don't know. And actually in cancer, perhaps maybe a little bit differently than heart disease, and you heard about subpopulations, men, women, I think cancer takes it sort of a step further. Cancer is not one disease. Cliff knows this well. It's about 200 diseases. So if each of us, the 5 of us here, I'm not trying to leave you out on purpose, were to develop breast cancer, in all likelihood, we might have very different cancers. And so if we're going to study, well, what works for a woman in her, pick an age group with breast cancer, and we were in the trial, if they didn't know anything more about us or about our specific cancer than that we presented with a primary cancer of the breast, that would not give you a very good comparison at the end of the day. We now know, for example, with Herceptin, that there is a population of women who have a genetic profile whose cancer looks a certain way that will benefit from Herceptin. There's a whole bunch of women who have breast cancer who won't. And that might be just a drug that they would get that would not help them, would not hurt them. But what if it's a treatment that could hurt them? What if it's a very expensive treatment? What if the fact that they're going down one road means that they've forfeited going down another road? So I think one of the potential upsides of comparative effectiveness research, if done right, transparent, looking at subpopulations of people, applying the knowledge that we've gained through investment in medical research, is that we actually can study the right groups of people in the right way so that we can get the right drug to the right person at the right time. Then we really will have accomplished something for patients, and I think at the end of the day we might also have saved a little money in the healthcare system. Now that's, I think, the hope that everybody has, and we're a long way from that. When I talk to our medical folks down in Atlanta, the American Cancer Society has some of the best of the world, and I ask them about this, and the thing that they keep coming back and say, well, in cancer, the gold standard is the randomized controlled clinical trial. But yet, other than children, fewer than 5% of adults with cancer enroll in a clinical trial. So we have an infrastructure out there. We have the NCI designated cancer centers. We have clinical trial cooperative groups. We have all these smart people. But yet, in clinical trials today, which is a version of comparative effectiveness, comparing standard therapy with something else, could be standard therapy plus something, could be a whole new drug, we only have 5% of the patient population at best that are enrolling. So to your point earlier about if we're building on history and the data that we already have, well, we've already got a problem because we don't have most cancer patients in the system. Then you add to that the fact that a lot of cancer treatment is done in a way that the phrase is off-label. It sounds very nefarious. I'm not a doctor, but those in the audience know all about this. So a drug company goes through a process, goes to the FDA with an indication for a drug, brings its proprietary data to demonstrate what's happened, gets an approval, slaps a label on it, goes out there. Well, most cancer treatment, estimated 50 to 70%, is ultimately done off-label. That doesn't mean it's done in a back room somewhere by somebody that doesn't have a medical license. It means an oncologist is basically taking a product that was labeled for this and trying it in this way for that. And there are compendia, there are research journals out there to try to allow for some learning from that, but at the end of the day, we're not actually really learning from that. And so we need better outcomes data. And I think that, again, going back to my conversations with our chief medical officer and our scientists at ACS, over and over and over again they say if we could do comparative effectiveness research right for cancer and we could get outcomes data to patients, to doctors, and out in the community, we would really have accomplished something. And then if you had a way through technology, health information technology in particular, to transmit that data so that it goes into clinical practice, like you were saying, Lisa, I think then we might really have something. But again, we are a long way from that. So I want to go back to saying it's both not the world's greatest thing, it's also not the world's worst thing. I think it depends on how we take the kernel of the idea that we need to know more about how an individual patient will respond to an individual thing that happens to them. And we talk a lot about drugs, but actually, let's look more broadly. I mean, we should be looking at this in prevention and early detection. There's a lot of discussion about what are the best ways to detect breast cancer, and we have the best that we have, but someday we hope to have better, and how will we test to know? Phyllis, you mentioned lung cancer. There's a great deal of debate about what's the best way. Do we have a way for the population to know, to save lives from screening for lung cancer? And the American Cancer Society is an evidence-based organization. So we're all about data, and everything that we do in advocacy and public policy and in translating that into legislation and regulation goes back to the data. So we're all about wanting to have better outcomes information that we can then put into practice. And I think to the point about cost and coverage, I mean, this is where it really does start to get very difficult for people. And people throw around all kinds of, back to the inflamed rhetoric, terminology about, what goes on in other countries and rationing and long lines. I think that we first have to get the science right, and we're not there yet. And so if we focus our energies through the increased resources in the stimulus bill, through some of the mechanisms that are now being set up, get the science right, there may come a time when we want to talk about what's rational care versus rationing of care. And absolutely the patients need to be at the table when that conversation happens. So I think I'll close, because I want to make sure that Cliff gets a chance, with saying it's also not just about are you going to live or die if you get a particular treatment. In cancer, there are harms that can come. I mean, some of these treatments are very, very toxic. And so you have to look at also the quality of life of the patient. And you get into these conversations of, 10 days of median survival for drug X that costs, tens of thousands of dollars. And what's the quality of life of that patient? So I think, Phyllis, you mentioned all the things that need to go into what we mean by outcomes research. And it's not just did the patient live or die? Did the cancer go away? Did the cancer not progress? What was the quality of life of that patient? I mean, all the pain and side effects, late effects, and all of these things need to be brought into play. And I think cancer can be a good case study. In fact, we were very pleased to join with a number of other cancer organizations in presenting a report in the context of this whole stimulus process, using cancer as a case study and talking about, trying to lower the rhetoric a little bit and talking about some of the important components of the design of this system if we're going to get it right. So I really appreciate the opportunity to be here. I think you've heard that all of us are working to make sure that the voice of the patient is being heard in this healthcare reform debate. CER is but one of many issues. For some people, it is a proxy for a whole lot of other issues. And just like public plan is a proxy for a whole lot of other issues that we're now starting to see. And I think if we could sort of step back from the bridge that says it's the best thing ever, it's the worst thing ever, and look at how do we make it work for patients, we will all be better off. So thank you very much.
Great, thanks. Okay, Cliff.
Well, I have to say it's very tough to follow all these eloquent presentations, and Rhonda's very passionate presentation as well. So maybe I'll just talk about the Tour de France. I will say, I want to throw out a sort of a crazy scenario that seems to have nothing to do with this discussion. Imagine instead of that 1,000-page cap and trade bill that was negotiated. Instead of that, Congress decided to tackle the greenhouse gas problem by saying, all right, we're going to pick the 10 most fuel-efficient cars and mandate that everybody in the country, with some exceptions, has to use those cars. Now, first they have to send one of those Dick Cheney hit squads out to Long Island to my brother-in-law's house and wrestle my brother-in-law to the ground and impound his 67 GTO and replace it with a Prius. And then after they've gotten away with that, then we could evaluate how this was working. And we might say to ourselves, it's a radical idea. It's absolutely crazy, and we can't imagine that happening, but it's doable. And the reason it's doable is because we can measure fuel efficiency. We know that there are small differences in combustion engines and drivetrains and the aerodynamics of chassis and whatnot. But when it comes right down to it, they're so substantially similar that gasoline is going to combust in the same way through all of them. So you can take this process, and at the end of it, you have a good sense of which cars are more fuel efficient than others. Not so with the human body, and not so with drugs, most pharmaceuticals out there, and not so with most pathological conditions that we are all talking about, whether it's heart disease or cancer, which between the two of them kill pretty much 60% or account for 60% of the deaths every year. So, and even the other complicated, if you look at the 15 leading killers in the United States, which account for, say, 85 to 90% of all deaths, all of them are complex in their own way. And the patient populations are all complex in their own way. We know this through comparative effectiveness studies. We know this through the old term that I used in the old world, which was clinical trials, which Wendy had mentioned and others have mentioned. And it's essentially the same thing. You're looking at a value proposition of efficacy and safety and tolerability and making sure that one drug is a little bit better than the class of drugs already been used, or in some ways no worse than in the case of cancer many times. And I can tell you that in 200 years of this history, what we've discovered is two things. The first is there's an incredible variability in the responses of patients. And the second is that these so-called randomized clinical trials, the gold standards, actually have a pretty spotty record, all told, of telling us that. So you take, for example, early stage colon cancer. Now here's one of those tricky areas, and John can talk about this, and Wendy, and of course we have another cancer expert in the room too, Hela Modelmog, who's the CEO of Susan G. Komen for the Cure, and one of my old colleagues, and a wonderful woman also. And so I can tell you that we have, so if you take early stage colon cancer, you've resected the tumor, you want to know, do I give chemo or not? There's a standard of care that's been used for a long time in later stage colon cancer. So you go through this process of gathering the data. You know, we talk about the importance of data. So they have done multiple trials on this. The first 5 trials that they did, major randomized controlled clinical trials, a few of them were NCI sanctioned, a couple of them were overseas. They looked at the data and they came up with radically different conclusions. One said that 67% of patients, there was a 67% reduction in death rates among patients who were treated with the standard chemo. Another said there was a 28% increase in deaths. So they gather these trials together and they create what's called a meta-analysis. And they put them all together and they try as best they can to connect the data in meaningful ways. And lo and behold, they come up with the answer, there's no significant statistical benefit, okay, to giving chemo. Well, end of story? No. Unfortunately, another whole series of trials and another whole meta-analysis come, and they come up with the opposite conclusion. So after 13 years and 9 clinical trials and 2 meta-analyses and 3,000 some odd patients, you have one big academic shrug. Now, if this sounds like a crazy example, it's actually, you cannot pick up a medical journal these days without seeing epic uncertainties played out every week or so. You want to know whether Tylenol, which is a drug that cures my headaches better than anything else. I mean, in the words of Charlton Heston, if someone tried to take my Tylenol away from me, they'd have to arrest it for my cold stone hands. And yet, we know that in some patients, in some cases, over some use of time, it's the largest cause of acute liver failure. We know that certain asthma medications make lives brilliant, wonderful for many people. In others, they drop dead. We know the same as Rhonda and Lisa eloquently spoke about in terms of heart disease. There are a range of medications that work well in some or another. And so when you get into this idea that we're going to be able to take the layer of clinical effectiveness that we've discerned from clinical trials and add a new layer of cost effectiveness to the analysis, and you say, do we have the data? No, we don't. We do not have that data, and we will never have that data, frankly, because what it takes to do those kinds of studies is enormous. So let's say you've got your 11 ACE inhibitors that are on the market now, and you want to figure out which is the most cost-effective, clinically effective, best tolerated, least likely to end up with adverse events in the greatest number of people. In order to do that study, and I'll get a little scientific here, to statistically power that study, okay, for 11 different medications over, say, 10 years of use, and hundreds and thousands of patients, millions of patients perhaps, to get the data you would need, it would be millions of dollars to do that study. We know how difficult it is without that in the case of, or perhaps, I mean, in the case of the Vioxx, the adverse events that we learned about in Vioxx, we didn't learn about those in the early clinical trials. We learned about them years after they were on the market, where millions of people were taking this drug, and we could see in a subset of patients that they were having these, this increased risk of cardiovascular problems. And yet, we still don't know, looking at those subset analyses, why each of those patients were having those problems, which in each case it was. And I tell you that in the case of cancer, where you have extraordinary heterogeneity in these diseases, an incredible individuality in subgroups of diseases, where genetic mutations might lead to any number of whether someone responds well to a drug or not. That is pretty much the state of play across the board in healthcare today. So that said, we haven't addressed the elephant in the room. And the elephant in the room is cost. And we've all kind of danced around this. We know that the power of personal stories, and to say that we all absolutely need to have the access to the drugs and procedures and surgeries that we all need and want. We have to address the cost situation. And here is where I think we're asking the wrong question. The question that comparative effectiveness fundamentally asks is, which of these two $60,000 a year Genentech drugs is least likely to be beneficial in this particular case? And my question is, how do we make that $60,000 drug a $10,000 a year drug or a $2,000 a year drug? And that's really the fundamental question we should be asking. Not how do we make these choices, that can take 10, 12 years to answer, and then by the end of it, there's a new class of drugs offering a new class of benefits to a select group of patients that we need to test, and through this process, we've now closed the door. This process of comparative effectiveness could have the adverse effect of raising the barrier to entry, because when you limit the class of drugs that come in, you're actually potentially increasing the cost of drug development. So, because the prize is so great, and so everybody has to do what they can to make sure that they're getting into those formularies. So I think that what we want to do is look hard and fast at why these drugs and procedures and the cost of care is so expensive here when it isn't around the world, and for the same or better benefit in other countries. And so that's a fundamental discussion we have to have. It doesn't mean that we can't ask these questions, but I would like to leave us with that little reality check, since we have some very persuasive speakers talking about some of the issues. And with that, we can talk about the Tour de France.
I hope you'll announcement. 10-minute warning. Okay, so I'm sure we have an awful lot of questions. Let's start on this side of the room, and if you could just speak a little bit loudly because we don't have the mics.
Jan Hamilton. Clearly we don't have a cookie-cutter approach, and maybe we never will. So if we want to get a baseline, we heard in the last session with Phyllis that we can now analyze the fetus blood and cells and know something about what could happen in that organism 30 years from now. Do any of you see that kind of testing so that we could individualize this to the point that I could know what might be happening in my body 20, 30 years from now, address a preventive modality? I feel sure the healthcare budget's going to be broke by the time I'm the age of my mother. And what can I do to contribute to saving national healthcare dollars in the Medicare budget and increase my quality of life? Is there any lab anywhere that I can go to and measure as an adult what could happen down the road in my life and get involved in prevention?
Not yet. There are some genetic tests, which you know, certainly for BRCA1, BRCA2, which we discussed in the other session. But I mean, that is one of the questions, actually, that hasn't been addressed, the whole idea of personalized medicine, which was also part of this session, which we haven't gotten into, and what the effect it's going to have on that. I mean, a lot of people are talking about personalized medicine. There is some now, and supposedly there will be more later. And that, of course, will just complicate this further, because you will be able to tell, or someone will be able to tell from genetic markers what therapy or therapeutic is going to work for you, and Herceptin was given as an example, and that's a perfect one. You can tell whether a particular drug, whether that drug's going to work from the type of breast cancer that you have or not. And there's research going on all the time to understand genetic markers, and there's a lot of research, because we've been speaking to people, a lot of molecular diagnostics that are being developed that can determine if you actually have a condition, if you're vulnerable to a condition, and how to treat that condition. But a lot of this is still in research and development. But one day it will be there. And that, I think, just complicates everything more, because then you're really looking at, not that everybody is different. Everybody is not going to have their own, personal medicine. But there will be subgroups of people that will have that we will know will respond to certain therapeutics and others that won't. I would just like to add something. I mean, everything you said, obviously we agree with. I mean, I think it's an impossible task, frankly, to have this comparative effectiveness on drugs and devices for all the reasons that everybody spoke. But I do think that there are certain things that if we concentrate on could be positive, and that we all know there are regional differences. We know that in some parts of the country everybody gets a mastectomy, in other parts of the country they get lumpectomies. Clearly there's something going on there. I mean, that needs to be addressed. Lisa referred to this. There are some, at least 17% of cardiologists, that know that there are sex differences in cardiovascular disease, which leaves the rest of them that don't know that. It would be interesting. We need to have a dissemination of this information that's going to get out quickly and get to everybody, all the practicing cardiologists and primary care and internists, so they can diagnose or at least refer women to cardiologists when they suspect that something is happening. So I think that there are practice guidelines, there are best practices that we know that are not disseminated throughout the country. And I mentioned this, I get confused because this is my third panel, but did I say this already here or someplace else? But there are, we know that it's years before research is translated into care, and it takes years for doctors. Companies come in all the time talking to us about what doctors don't know and why they need continuing medical education. So I think if we're looking at service delivery, practice guidelines, performance, outcomes, that there are some aspects of this that actually I think do make sense and can be it can be used so that we're all getting better care, dependent upon what the current standard of care is. It's the drugs and the diagnostics and the individual differences where I think it really gets tricky, and I just don't see how that's going to be accomplished.
I think if I could just touch on that just a minute. If you look at one of the great success stories in cancer, it's the battle against pediatric leukemia, ALL, acute lymphocytic leukemia. The way this battle was won was taking drugs that were by themselves inefficient and ineffective and actually quite toxic. And they would try various drugs in a linear fashion, one after the other, and all of them were failures. And this is a horrible, horrible way to die if you're a child. I mean, I don't want to go into that here in this pleasant conversation, but they were trying everything they could until somebody got the bright idea of combining them. And they found that these synergies, surprising synergies in some cases, because of the way each of these drugs attacked at different points in the cell cycle. Now, this was based on no knowledge at the time. And so it was really serendipitous. And as they approached new combinations of things, they started to raise the rate of survival, 5-year survival for children with ALL, from 0 to now close to 90% over the years, basically by using this process of figuring out what works in different combinations. And there are more than just drugs at work here. The problem is that there was no specific test. Now, you raised a good question about pharmacological tests. You can do certain genetic tests to know whether one of those drugs is less likely to have a response. You can do a genetic test or other markers to look to see which one of those is likely to be not tolerated, or maybe won't work on a specific target that you're hoping for. But even that, you're not going to be able to find a test that tells you that something is going to work. And the perfect example for that is Herceptin. So here's this drug that everybody talks about, the ultimate targeted drug, that's supposed to work on women that overexpress a protein called HER2. Except for the fact that in study after study, when you break down the data of who responds and who doesn't, it doesn't conform to women who are positive for HER2. It's all over the map of responders, and they don't quite know why that is. And so if you were just to look at the HER2 positive women and exclude women who tested negative, one, you might be excluding people that were actually HER2 positive in some of their cells, and I know several people like that. One of Phyllis and my former colleagues. Or two, you may find that that wasn't really the marker that was going to tell you what was likely to be effective or not. And this is really, again, cancer does account for quite a lot of the illness in the country, and between that and heart disease, if you take these two examples, it's almost impossible to find a magic bullet test that's going to be able to pinpoint with any kind of accuracy responders and non-responders.
Go ahead.
I just wanted to comment on the comment on personalization as a complication. I really look at it as a solution. And, going to the cancer phenomenon, why should we accept a 30% response rate as a best-in-class for the drug? If you identify a patient, you should be able to get response rates up into the 89%.
Well, I'm not saying it's complication. I'm just saying in comparative effectiveness, that's an issue. I think it's a great thing if you can
But it
make
actually
personalization.
simplifies comparative effectiveness because it has the opportunity to identify patient subpopulations that will react to the therapy. And in order for the research to move forward, is really a culture change. It's a culture change in the industry, pharmaceutical industry, that really hasn't happened yet because of the way they approach their markets. I think also a culture change in the FDA. I don't think they've been keeping up.
And that's part of what Cliff was saying with asking different questions and reframing the whole way we do things. I'm going to go quickly, because there's a lot of hands. Matt?
Cliff is right, but I'm afraid this panel is mostly a scam. Comparative effectiveness we're talking about is let's try a big name pharmaceutical, branded pharmaceutical, put it up against a generic, and see if it was better. We have a great example in heart disease where we're spending between 100 and 200 billion, depending on who you believe in, on angioplasty in men with angina. The 55-year-old white male will give me in 10 years, right? Which we now know doesn't work as well as medical management, and yet we're still spending that money. You mentioned practice variation. So it's a bit like when George Bush and George Soros were arguing about Iraq, and someone said to Soros, well, you know about nation building? He said, yeah, I know enough about it to know that we've gone to Iraq first. You wouldn't go to cancer first, and you wouldn't go to somebody like Rhonda, you wouldn't look at a case like Rhonda's. Rhonda, an amazing medical story, and a great bus driver. And by the way, spending a ton of resources on a 36-year-old woman with children is a great use of medical resources. But that's not the place you start. You start about the stuff 30 or 20% we actually do know about.
Right, that's
So
it.
sorting out cancer, and frankly some outliers in the heart disease group, talk about comparative effectiveness, is really not what we're talking about here. And if we're prepared to take Cliff's point and say, well, okay, nothing works, we can't figure it out, it's going to be too complicated, it's going to take 15 years, then the only answer is to do what foreigners do, which is not to do rational allocation of care, but say, here's a bucket of money, you guys in the healthcare system, patients, figure it out. Because the alternative is to say we're going to spend 25, 30, 35, 40% of the GDP on healthcare and not have schools, roads, cities, and all the rest.
Can I just comment on that? One of the reasons I got trotted out here as cancer is because we are the poster child in this debate. Because cancer treatments are the headlines that you see when people talk about what's wrong in our healthcare system. They talk about those $100,000, $200,000 therapies. And if we could just stop spending $100,000 and $200,000 on treating cancer, And the other thing that we didn't get a chance to talk about here, which goes back to your question, which is the other side of this, which is what can we do to prevent people from getting cancer in the first place and then save the money on these not only very expensive but very toxic and difficult and either horrible treatment or horrible death. And we know how to prevent 60% of the deaths that are happening in cancer today. And there are things you can do. You don't smoke, you quit, you see your doctor, you control your diet. I mean, these are not sexy. These don't get the headlines. This is not what Congress is talking about. But guess what? We got to do all of it. And so the reason that cancer is in the center of this debate is because we are being blamed. The cancer patient is being blamed. The expensive heart surgery is being blamed for, well, if we just stop doing that, we could save our healthcare system billions of dollars. So I take a little bit of exception
Lisa wanted
to
to
your
make a
comment.
comment.
No, I just think that, and maybe that wasn't clear from what I said also, is that there's so much, the part of the promise is that there's so much basic information that we do have now about cardiovascular care that's not being implemented. And so if this can help have that implemented, that's what would be a positive. And I think that's not
In the back?
I want to amplify what Matt said, and really what Wendy said to me back the last time I saw her, which is that most of this money can be saved by prevention. As Wendy pointed out, I was talking about obesity at the time, and various corollary diseases of obesity. And Wendy said, did you realize that 40% of cancers are probably avoidable just between obesity and routine inspection by doctors?
right.
If I remember the number correctly. And that alone is a staggering statistic. Is having had a mother who died of cancer, I can tell you the drugs were giving her maybe 3 months life expectancy. They were nothing compared to the kinds of savings we just talked about. The second point I wanted to make is in the industry I come from, which is IT, I used to work at Google. We deal with data all the time that is not randomized clinical trials. Google does not have the luxury of running a randomized clinical trial to figure out where you click on this ad or that ad. So rather than perspective, we go with retrospective data and we analyze it and figure out what is more likely to occur in a messy world with messy data. And we do it pretty easily, honestly, witness the profitability of that company. And at the end of the day, I guess I wonder, and you should tell me because you're the expert, it's my impression that if you look just at countries, just at France, for example, compared to the U.S., or you look at Germany compared to Germany, of the civilized Western countries, which offer pretty much the same basic drugs, the same basic treatments for the same basic diseases, again, holding cancer aside for a second. If you see regional variances there, my impression is you do. Why not go back, look at dirty data? Don't treat that as a forward-looking clinical trial. Look backwards and say, what is it that makes those numbers different? Why is it that French live longer? Why is it that those women have fewer heart attacks, given that they clearly are not eating less butter? And that, I think, is why is there no focus on looking at actually country-level differences and examining where the differences are coming from, since they seem to be substantial based on life expectancy and outcome, and clearly it isn't high.
I think actually Google is the best epidemiology there is. I mean, I really did. I gave a talk about that at the NCI, basically Google as epidemiology, because when you take huge amounts of data and you're not afraid of GIGO, garbage in, garbage out, you assume that the volume of data is going to sort it out in the end. That's when you start to get some good answers. And they're not, maybe not, perfect answers, but oftentimes the perfect is the enemy of the good. And, you have basically an efficient marketplace for knowledge that bubbles up through Google. I would say that I totally agree with the comments that were made about prevention. I think that if you couple prevention with very, very early detection, when before, say, a disease like cancer goes through this march of heterogeneity and gets more and more difficult to cure, you can actually approach it from a much cheaper standpoint too. And we can use a lot of the generic and standard of care medicines in the past. But I'll tell you, it's even if you take patents out of the picture and you look at old world drugs, that were developed 50 years ago, they're still priced too high. And I think you have to ask that question: why are these drugs so expensive? What are the barriers to entry into the marketplace? How do we make more efficient, get information more efficiently, like via a Google approach rather than through the randomized clinical trial that spends huge amounts of money and never gives us much certainty? And so I think you just have to reframe those questions.
Let's take one more question. Go ahead.
In the stimulus legislation, there was $30 to $40 billion set aside for building the HIT infrastructure to support this, and there's been sort of a parallel process going on in terms of determining how those monies are going to be spent. And what's sort of interesting there is I think there was an initial bias, largely an industry bias, around decision support and building data for comparative effectiveness as being the drivers of that process. But in the process, what sort of happened, it's sort of fascinating, is that there was a list of metrics that were created to say, what is it that we actually want to accomplish? And when you look at that list, what's fascinating is it has far more to do with changing physician behavior and changing patient behavior than it does about decision support or comparative effectiveness. And it's a kind of an interesting example of how, as you get into this, when you start really looking at it, how do you get costs out of the system? It's not really about clinical decision support. It's about patient behavior change and physician
behavior change.
Right. That's right. And that obviously would be the positive of this. So, as I said, I think there's, we all said this really, there are positive ways of looking at this, dissemination of information that's already known, education of the patient. But there's also, we can't get into all the details here, and we're running out of time, but one of the other issues that my organization is working on is that they're proposing all these cuts in imaging and screening. Well, if you're talking about prevention and early diagnosis, then you can't cut the imaging and the screening. Yes, it may be overused, and yes, there are probably places where it can be reduced, but cutting across the boards is not the way to do it. So there's a lot in there that's complicated. That could go both ways.
And the whole point of this was to be a little bit disruptive in that nobody is saying there isn't tremendous value, and we obviously we have to do something in comparative effectiveness. We need more information. We need more evidence. What do we do with it? Do we have enough people? Academy Health has gone on record. They don't even have enough researchers to do the research once we agree what methodology to use. There aren't even enough trained people to do what needs to be done. That's fixable. But how we use this information, who are we leaving out? They're just issues that have got to be included and considered as we go down this path. I'm not even sure when we go down the path $1.1 billion gets you anywhere close to what you have to do. So that in and of itself is something of a joke. So let's just be real about what we're trying to accomplish and make sure we get it all at least out there and starting to talk about it. So I'm getting a sign that we're late. If you'd all please help me thank our panelists.